Hello, everyone. Thank you for coming to this year's Consumers First webinar, Priorities in the 2026 MPFS and OPPS Proposed Rules. I'm Mike Persley, a Strategic Partnerships Campaign Manager here at Families USA, and I'll be your moderator. Along with myself are some of my esteemed colleagues. First, we have Jane Sheehan, our Deputy Senior Director of Government Relations. Then we have two members of our policy team, Aaron Plotke, Associate Director of Healthcare Innovation, who will present on the Outpatient Prospective Payment System, or OPPS, and Alicia Camaliche, our Senior Policy Analyst, who will present on the Medicare Physician Fee Schedule, or MPFS. Next slide, please. So last month, the Trump administration proposed their annual changes to how Medicare pays for hospital care through OPPS and for physician services through MPFS. These proposed rules take important steps forward in increasing payments for primary care and for reining in key payment distortions that drive hospital consolidation. At the same time, they also roll back requirements that drive health equity improvements. Because Medicare payments set the benchmark for how all other healthcare is paid for and delivered, these rules are not only important for our nation's seniors and all those who rely on Medicare, but also for the millions of people who rely on Medicaid and commercial insurance for their health and healthcare. Therefore, it's critical for us all to come together as organizations representing consumers, families, workers, clinicians, and employers to ensure the administration prioritizes pro-consumer policy changes in this year's Medicare payment rules, and in doing so serves as a counterweight to industry interests. CMS is seeking feedback from the public on its proposals, which are due for MPFS by end of day Friday, September 12th, and for OPPS on Monday, September 15th. Families USA, along with the Consumers First Coalition Steering Committee, has analyzed CMS's proposals, and we've written two comment letters detailing our feedback. Today, we'll highlight areas, good and bad, that we've identified as particularly important for advocates to be aware of and comment on that are critical to driving affordable, high quality, and equitable healthcare for everyone. Our hope is that by the end of our hour together, we'll have convinced you of the importance of these issues and that you'll join us join our comments by signing on in support so that we can send a collective message to the Trump administration that it needs to deliver affordable, high quality, and equitable healthcare for our nation's seniors. We'll be providing those comments to you in the coming days. Before we dig in, I do want to run through some just general ground rules. This webinar is being recorded and can be available to you upon request. As an accommodation, we're also more than happy to provide written notes and other resources following the call. Please also note that AI bots, including those that take notes, are not permitted to join the meeting and will be removed. And lastly, please put questions that you have throughout in the question and answer box, which we'll have time to answer at the end of everyone's presentations. So now I'm going to pass it to you, Jane, to talk a little more about why it's so important for us to provide feedback to CMS on these proposals.
Great. Thank you, Mike. And thank you to everyone for participating today and for past support, both engaging in these comment letters in the past and just elsewhere in healthcare advocacy. So before we dive into the specifics of the proposed rules and the comments, I just wanted to take a minute to reiterate why it's so important that diverse stakeholders are engaging in these annual regs. So again, I think, as we've talked about in years past and in past comment letters, these are Medicare payment policies, but they have broader implications for private market and for Medicaid. And I think as we regularly discuss amongst partners in this group and many on the call today, it's so important to engage right now because of the cost of healthcare is rising and it is crippling families across the country. And we included just some key stats on this slide to help illustrate that. But really across the country, people are sounding the alarm. The cost of care is too high, the system is too complex, and relief is desperately needed. The system's not serving the people it's meant to. I think we see that across, the affordability crisis. This year, nearly half of Americans struggle to afford their health care due to high cost, and citing that as a reason. Even families with commercial coverage are spending a really large portion of their monthly budget on healthcare costs, and we have over 100 million families grappling with medical debt that they may never pay off. I think especially coming off of the summer and this year's reconciliation bill, the affordability crisis is likely to only get worse. So it's really more critical than ever that we're pushing policymakers and regulators to use all of their levers to help improve incentives in the system, so that it's delivering on the value and quality that it's supposed to. So in terms of the focus of kind of today's comments and in our analysis of these rules, we know that a leading driver of these rising healthcare costs are high prices that have been enabled by unchecked industry consolidation. This is, of course, made worse by broken financial incentives in our healthcare payment system that are incentivizing and driving further consolidation and are failing to hold the system accountable for affordability and quality. So, as we'll talk through today, these proposed rules and corresponding comments are an opportunity to move the system's incentives in a more positive direction for consumers, for workers, for healthcare clinicians, and for large and small employers, and many other stakeholders that are joining us today. It's important for us all to come together because we know that healthcare industry, including all the major hospital systems, large insurers, specialty physician groups, and other special interests, they'll be commenting. And I think across the board, there will likely be a lot of pushback on some pro-consumer reforms that we see or that we'll be advocating for, because those reforms may threaten their status quo and bottom line. So our collective groups coming together can really provide an important counterbalance and an alternative viewpoint for rulemakers to see when we are thinking through how to design healthcare payment to really deliver for people that it's supposed to serve. So I think just to reiterate, the forthcoming positions and recommendations are grounded for the most part in long-standing policy positions held by the Consumers First Coalition and based on input from our steering committee over the years, including kind of based on our very recently published legislative and administrative policy agendas that we released earlier this year that we'll be sure to share in the chat and in follow-up for further reading if you're interested. And I think finally, again, just to reiterate, submitting these formal comments through these periods that the administration opens does create a legal obligation for regulators and administration officials to consider and respond to our feedback. In addition, in subsequent months and years, if there is any litigation or industry pushback against pieces of these regs that we are advocating for or not, our comments are part of the administrative record and can be useful in that litigation, kind of making sure that our voices are continuing to be heard down the line. So hopefully I've kind of added to the case that we're going to make today. And without further ado, I'm going to turn it over to my colleague, Erin, to get us started on the major pieces of focus in the outpatient rule.
Great. Thank you, Jane. And thank you, Mike. So just to say again, for those who don't know me, my name is Aaron Plotke. I'm the Associate Director of Healthcare Innovation here at Families USA. And yeah, so I'm going to run through three major proposals that we've been tracking in CMS's Outpatient Prospective Payment System proposed rule. And they're really making some major changes to how Medicare is paying for hospital care, and that we found are particularly important to the health and healthcare of our nation's families. So to start us off, CMS proposed a number of changes that largely weaken federal price transparency rules and really undermine our ability for people to know the price of healthcare before they receive medical services. And so I think most importantly here is CMS is proposing to continue to allow large hospital systems to post algorithms and price estimates instead of their actual negotiated prices in dollars and cents upfront. Specifically, they are allowing hospitals to calculate an estimated price based on historical payments they have received, instead of requiring hospitals to post their negotiated rates in dollars and cents upfront, so consumers can actually know what they're being charged for hospital care into the future. At the same time, CMS is proposing minor improvements to increase enforcement and strengthen compliance with the hospital price transparency rules by requiring hospitals to list a senior executive's name in their pricing file that is tasked with overseeing the accuracy and completeness of the hospital's published pricing data. So in response to these proposals, we are strongly urging CMS to require hospitals to post all of their negotiated rates in dollars and cents without exception. No estimates, no algorithms. If hospitals can generate a bill based off of negotiated rates for each item in service, they should be able to share those prices upfront with the actual purchases of healthcare. Moreover, as you can see on the slide, we are recommending CMS finalize but strengthen its proposal to list a hospital executive tasked with overseeing the accuracy of the hospital's published prices by requiring that that executive actually signs their name, confirming the accuracy and completeness of the data to further increase hospital accountability to posting accurate and upfront prices. And lastly, given a significant number of hospitals are still out of compliance with these rules, we are continuing to urge CMS to increase the financial penalties for hospitals' non-compliance, as well as separately establishing a process to publish and pair quality information with these prices. So not only do we have transparency on the affordability of hospital care being delivered, but we also can understand at the same time the quality and the overall value and cost effectiveness of the care that's being delivered. So the second piece we wanted to cover on the OPPS side is CMS is proposing to enact site-neutral payments for drug administration services that will ensure consumers pay the same price for the same services for physician-administered drugs in more outpatient settings, including those grandfathered hospital outpatient departments that were originally exempted from previous site-neutral payment policies, and would really help rein in a key driver of healthcare consolidation and high hospital prices. And so this is a very exciting proposal. It represents the administration taking an important step towards a long-standing priority of this coalition and this movement. And so naturally, we are expressing our strong support for CMS to finalize this proposal. At the same time, as you can see, we are expressing concern and opposing CMS's proposal to exempt a significant number of large hospital systems from this site-neutral proposal, including rural sole community hospitals. Of course, we recognize that certain rural and safety net providers may require additional financial support to move into site-neutral payments. And however, we believe waiving site-neutral policies for broad categories of hospitals without targeting those hospitals that are truly most in need would risk undermining the goal of site-neutral payments and would allow large hospital systems to continue to charge rural consumers and their families who are particularly financially vulnerable inflated prices for routine care. And so specifically here, we found Medicare's definition of rural sole community hospitals as poorly targeting the actual rural and safety net hospitals that are truly in need of any such payment adjustment. For example, we know the Mayo Clinic Health System is a near monopoly nonprofit system in Southeast Minnesota. It makes over $1 billion a year in net income, or for a nonprofit, that's margins, and yet operates 2 hospitals within Minnesota that are identified as rural sole community hospitals that would be otherwise exempted from site-neutral payments if this exemption were to go through. And so if CMS were to move forward with any exemption of any kind for site-neutral, we would urge them to focus on the providers most in need, such as including independent rural hospitals that are not affiliated with larger, more wealthy systems. And so the last piece I wanted to cover today was CMS's proposal to repeal a number of very critical quality measures that would have held hospitals accountable for health equity and the social drivers of health. So specifically, what CMS is proposing to do is to remove these 3 measures from the hospital outpatient quality reporting program, including the hospital commitment to health equity measure, which assesses the extent to which a hospital and its leadership are taking concrete and meaningful steps to drive equitable and inclusive healthcare delivery through efforts around data collection and improved quality improvement, etc. The screening for social drivers of health measure, which determines if a hospital has been screening their patients for health-related social needs, such as food insecurity or housing instability. And the last measure they're proposing to repeal is the screen positive rate for social determinants of health, which would determine the percentage of patients who are screened and had at least one health-related social need. And so as you can see, we are strongly opposing CMS's proposal to repeal these measures as they are critical to helping drive meaningful improvements in healthcare and quality and health outcomes. And we really firmly believe that hospitals should be held accountable for healthcare costs and quality, and that should include the non-medical factors that drive more than 80% of what makes all of us healthy. And so with that, I'm going to turn to my colleague Alicia Camaliche to discuss some of the key proposals we're tracking on the Medicare physician fee schedule.
I'm actually really quickly going to throw it to Sophia Tripoli, our senior director. I think maybe just in case she has any last minute thoughts before I take over.
Thanks, Alicia. Very, very briefly, and good afternoon, everybody. It's great to see you all. I think, thank you so much, Aaron, for that run through. Just very briefly, just for folks who, in terms of the importance of these proposals on the policy merits, as folks know, and are probably aware, the federal administration has been implementing price transparency regulations for hospitals for the last several years, which was initially enacted under the first Trump administration. And as folks know, we've seen a really big trend towards most hospitals not complying. And we see a lot of different games that hospitals are playing. And ultimately, this piece that Aaron's lifting up about being able to post algorithms or estimates of what the price, the negotiated rate, is deeply problematic because the most important price, the price that tells us what the cost of healthcare services is actually being negotiated between providers and plans is the negotiated rate. And without that, we really are very disempowered as purchasers, whether you're a consumer, a patient, an employer, et cetera, a worker, from being able to understand what the actual cost of your care is. And so whether you're a consumer and you have the ability to shop, or whether you're an employer and you need that data so you can actually negotiate a better deal for your employees. So the piece about the price transparency and sort of the weakening of those requirements is really, really important to keep the pressure up in these comments and moving forward with the administration so they understand that we actually have to get to the negotiated rate to unveil prices so we can see how irrational prices have become in the hospital sector across markets, within markets, across the healthcare system. The other point just to lift up is on the drug administration services. As folks who know who've been in the fight with us over the last several years, we've been pushing for site neutral payments for many, many years, both legislatively and through the administrative rulemaking process. And what we've seen the administration do is actually take, as folks know, a piece that was in the lower passed through the House in the last Congress, lower cost, more transparency legislation, site neutral for drug administration services only, and do that through rulemaking. It's a major win. It's a big moment to get this into the proposed rule. And so first, I wanted to say also congratulations to everybody who's been pushing the administration over the last several years, the different federal administrations, to be more aggressive on site neutral payments. As folks know, this is a really important win because getting those same service, same price legislatively or administratively does two things. First, it helps to address the financial incentive to push that hospitals now receive to push patients to higher cost care settings, into the outpatient setting, and helps to address that, reduce that financial incentive. And it helps to address this growing trend that we're seeing across the market that's rampant, frankly, of vertical integration, of hospitals buying up independent physician practices to rebrand them just as outpatient departments, just so they can get that higher reimbursement for Medicare. So even though it's narrow, drug administration services, it's not everything that we want on site neutral. It's a major step forward, and making sure that the administration is hearing from us collectively as a broad set of stakeholders, consumers, workers, providers, friendly providers, employers, is really important, because you bet they're going to be getting a lot of opposition to remove that provision in the final rule. We want them to know that this is a major step in terms of reducing the cost of care and making the system actually work better. So with that, Alicia, I'll kick it over to you to get us going on the physician fee schedule.
Alrighty, hi everybody. As Sophia said, my name is Alicia Camaliche. I'm a senior policy analyst here at Families USA. It's great to be here with you all today after, a busy summer. It's thank you all for joining us and getting in the weeds of Medicare payment policy. The Medicare Physician Fee Schedule (MPFS) CY 2026 proposed rule contained a ton of interesting and impactful provisions. It was very dense. So during this call, I'm gonna cover pretty quickly some pretty notable changes, and I'm going to overview them pretty quickly. So, feel free to leave questions in the Q&A box, or reach out to set up some time with us to talk about these provisions one-on-one if you'd like a little bit of TA, learn a little bit more about the comment letter, or you want to get more involved in Medicare payment policy generally. So let's just jump right in. I can go to the next slide. Awesome. So some of the most notable changes in the proposed rule are updates to how payments under the fee schedule are determined and calculated. As a quick background for anyone who might not be familiar, Medicare uses something called the resource-based relative value scale to set payment rates for physician services. Each service is given a value in the form of relative value units, which I'll be calling RVUs, based on three components: physician work, like this effort and skills needed to provide a service, the practice expenses, so the overhead costs of providing medical care, think of the building and supplies, and the cost of malpractice insurance. So CMS uses these three components to estimate the cost of delivering a service and therefore the price. And so CMS is proposing to make two key changes to the valuation of physician services. And the first section we commented on in the letter in support of is to updates to the practice expense valuation for services delivered in the facility setting. Now, bear with me, I'm going to explain what that means. Specifically, CMS is proposing a reduction in the practice expense RVU used to calculate how much providers delivering services in the facility setting. So think of an HOPD hospital or another type of facility will be paid for a service. So as a reminder, practice expense RVUs quantify the overhead costs associated with delivering a service, so the cost of the equipment or keeping the lights on. This ultimately means slightly lower payments for services delivered in a hospital or HOPD, so slightly lower MPFS payments for those services. Another facility example is a skilled nursing facility. And the reasoning behind this is really that more often than not, a physician of the facility, the overhead of a facility that's covered for physicians delivering services in a facility is covered by the facility. And what I mean by that is, if a physician is delivering a service in a facility, the facility's already being compensated for this overhead through payments through systems like OPPS or other facility payment systems. So by lowering the practice expense RVUs, CMS is avoiding a duplicative payment, essentially. And this is all in pursuit of improving the accuracy of our MPFS payments. Importantly, any changes to MPFS must be budget neutral, meaning this reduction in payment to facility-based providers will result in an increased payment to independent providers. We support this change, but we are asking CMS to assess how many providers may be employed to a facility while still maintaining their own practice, just to get a little bit more information on that landscape. However, we're excited to support this change, and we do think it is in pursuit of improving the accuracy of our Medicare payment rates. On the next slide, additionally, CMS is proposing an efficiency update, which will update codes to adjust for gains in efficiency through a negative adjustment to the work RVUs that I previously mentioned for all non-time-based codes. So again, a reminder, work RVUs estimate the amount of time and effort needed to deliver a service. So basically, under this change, non-time-based codes like procedures and lab tests, many of which have been historically overvalued, will receive a negative adjustment. As a direct result, time-based codes, which are disproportionately delivered by primary care and behavioral health providers, and which are historically often underpaid, will receive a bump in pay. So we are asking CMS to adopt this measure, but as always, are asking them to be cautious and ensure that services that have been unable to benefit from gains in efficiency are not unfairly captured under this change. And when I say gains in efficiency, think of how technology, more familiarity with a service has allowed us just to do it faster and with fewer resources over time. This is something we haven't really corrected for previously and commonly in the MPFS. Another point I want to make in regard to both of these updates to the practice expense RVUs and to the efficiency adjustment is that through these efforts, CMS is moving away from reliance on the Relative Value Update Committee, or RUC. For those of you who may not know, the RUC is a committee of physicians ran by the AMA to inform MPFS payment rate setting. RUC surveys and recommendations have largely and historically been adopted by CMS despite significant concerns with survey reliability and real evidence that has shown in many cases the RUC has and sometimes underestimated resource inputs for services. These efforts demonstrate CMS is moving away from a historical reliance on RUC data to other empirical data sources, which we make note of and really support in our comment. We can go to the next slide. So the next section is the APCM add-on codes. So some of you may remember last year, CMS proposed and finalized bundled payment codes known as Advanced Primary Care Management Codes, which provide monthly payments to primary care providers for a variety of care management services. These codes allow PCPs to bill using a monthly bundle rather than a burden of numerous individual codes, which can create significant barriers for primary care practitioners. Ensuring better payment for primary care and better access to management services for patients broadly. Last year, we supported APCM, and this year, CMS is proposing to create add-on codes for behavioral health integration services so that PCPs delivering advanced care management services to patients with behavioral health needs have an easier time providing and billing for the additional work needed for behavioral health integration services. While this provision does not really address the long-term undervaluing of primary care under traditional fee-for-service, the provision is an important step to reducing documentation burden, improving flexibility of care delivery, and supporting the delivery of integrated behavioral health. Because of this, we're really excited to ask CMS to finalize this proposal, and also we're asking to waive cost sharing for patients receiving APCM services because of the preventative care nature of the bundled codes. And we can go to the next slide. Thank you so much. Next, CMS is also proposing to test a new model under the Center for Medicare and Medicaid Innovation, or CMMI. This model focuses on improving care and lowering costs for Medicare patients suffering from low back pain or heart failure. The model is known as the ambulatory surgical model, or ASM model, as I'll call it from here on out. ASM would test whether adjusting payments for specialists based on their performance across a set of specific healthcare quality, cost, care coordination measures. I believe there's also a measure on use of electronic health records and electronic systems. It's testing whether the function of that model increases quality of care and reduce costs for Medicare beneficiaries. The model is an important step in testing payment reforms that incentivize quality, the delivery of high-value care, but payments are still remain tied to fee-for-service Medicare Part B payments, meaning these payments are still largely tied to the volume of care delivered. If folks on the call are familiar with the MIPS program, the model is structured similarly to MIPS with a few key changes that we're always happy to talk about at another time or answer questions on if folks do have questions on that. But largely as a result of this, we are asking CMS to finalize the model. We're supportive of the model, but ultimately signal that we would hope to see models in the future that move further away from traditional fee-for-service. Additionally, in the comment letter, we are asking CMS to monitor components of the model to ensure model design does not create too many barriers to the success of small independent providers who typically face more challenges being obtaining savings or participating in alternative payment models. And we can go to the next slide. And so lastly, what I'm going to cover today, though I will note there are a few other small provisions we touch on lightly in the comment, are updates to the MSSP program. So our comments on proposed changes, we comment on proposed changes that would require providers in the Medicare Shared Savings Program, or MSSP program, to move into risk-bearing relationships faster. As it stands, inexperienced ACOs that are new to value-based care in MSSP and don't have a history of taking on risk are able to take on no risk during the first 7 years of participation by joining one of the one-sided risk options. This means for those 7 years, an ACO is not financially responsible for overspending on care or missing the benchmark/cost target. After those 7 years, these ACOs are required to transition into two-sided risk options, but have the option to move through a glide path of tracks that gradually increase the level of risk or the amount of financial losses an ACO is on the hook for. So under the proposed change, ACOs would be pushed into risk-bearing arrangements faster, having only 5 years before being required to take on risk, and would be moved directly into the highest level risk arrangement. We know two-sided risk is associated with increased savings and improved performance, and so we support providers moving into risk-bearing arrangements, and therefore support shortening that amount of time, the amount of time ACOs can spend in one-sided arrangements. But we also recognize this can be challenging for providers, especially physician-led ACOs with little experience in managing risk. And because of that, we do recommend CMS allow providers to participate in intermediate risk tracks before being required to move into higher risk arrangements. So essentially allowing them to move through a glide path of risk before being pushed into those higher risk requirements. And so that kind of covers a ton, and I know these are really, really jam-packed proposed rules. So happy to take any questions or pass it back to Jane or Mike. Thank you all.
Awesome. Thanks, Alicia, and thanks, Erin, Sophia, and Jane. It's reverse order. So yeah, that was a lot of information, and in many ways, that was a lot of very technical information. So we do want to open it up to all of you. If you have questions, we're happy to answer. So feel free to put your questions in the Q&A box, and we will get to as many as we can.
Mike, I might just jump in for 1 second while folks
Sure.
might be thinking of questions. And on the physician fee schedule, I think a lot of folks, as Mike and Alicia walked through, there's a lot of really technical, weedy policy changes to the way that Medicare pays for and reimburses for physicians. And as I think we noted at the top of the call, one of the reasons it's so important to be weighing in here is because the changes that Medicare makes to physician payment or to hospital payment really sets the benchmark for how other payers across the healthcare system, whether it's a managed care plan or a traditional fee for service or in the private sector, employer sponsored plans, set the rates for how care is reimbursed through those payers as well. And on the physician fee schedule side, it's a lot of technical stuff on, are we doing add-on codes? Are we shifting to value-based care and alternative payment models? Are we increasing the efficiency? Are we taking the recommendations from the RUC? And I think the big picture message here for folks is a lot of these changes, some of them are incremental, but some of these incremental changes are very important to broader system change. The changes that we're making to the advanced primary care management codes, adding in the behavioral health services are really important steps. It's not the end goal to get to more sustainable payment for primary care and behavioral health, but they help to equip primary care providers and behavioral health providers and those who are billing for those services with reduced administrative burden, with the ability to prepare themselves to get to a place where they can have a more sustainable payment model. And some folks might be wondering, why does payment matter, right? Like, we just want to have better access. But we know one of the biggest issues for primary care and access to primary care is this undervaluing and underpayment of primary care that has been longstanding for decades through the way the Medicare sets payment rates. So, and I would say the same thing for some of these changes to the work RVUs and the efficiency payments. This is all about these incremental changes that advocates and a lot of primary care docs and other folks in the sector have been asking for, that may seem sort of very technical and wonky and sort of around the edges. But if we make these changes, it actually can help strengthen Medicare payment, increase access to these services, and address some of these long-standing barriers that are, frankly, I think, leading to a lot of provider burnout from the primary care side in particular.
Thanks, Sophia. Any questions? Oh, here we go. We have a first one. I think this is for everyone. Are any of these changes of the sort that could eventually move towards a universal system? So it's multiple parts. Do you believe some of these changes could be utilized to eventually create a universal system, or are they a step backwards to enforce the fractured and unaffordable system we currently have? Anyone want to take that one? Sophia, you're muted.
Thank you, Mike. I'll jump in, and a beautiful question, and thank you very much for asking that. I think big picture, we want to get to a system in which all people have the coverage, the comprehensive coverage that they need at a price that they can afford. Obviously, we're in an environment right now where we've taken some major steps back from that vision, and so there's a lot of work to do in a lot of different areas in terms of the broader healthcare and healthcare justice fight to get folks the access to care that they need and they deserve. I think the changes that are being proposed are help in many ways to strengthen the underlying structure of how we pay for care in the healthcare system through Medicare. And I think if we can get those changes done right and done well and done efficiency, it actually helps sets us up for a future where hopefully we can achieve that universal system and have a sustainable payment structure underneath that system of coverage that can last long, long into the future. But I do think the two are very connected. By no means do these changes to primary care payments or to physician payments mean that we're going to get to a universal system. There's a heck of a lot of work to get there, but they do help to set some incremental steps in making the types of changes that we need to payment. And frankly, as you guys know, in our healthcare system, the way the delivery system responds is to the payment incentives. And so we got to get those incentives right, and we have to get them sustainable so that we can make sure that everybody can have the coverage that they need and deserve at a price they can afford.
Okay. Any more questions? Feel free to put them in the Q&A box.
And I think while we're waiting for more folks to use Q&A, I'll just jump in and say, so huge thank you, obviously, to Sophia, Aaron, Alicia breaking down these like really, really wonky policy areas. I think, often, we're seeing these huge rules come out of the administration, and it's overwhelming. And I think it's important for us as advocates to really help each other break them down. I think kind of related to, because this is, it's not a question in the chat, but it's a question that's been coming up in some of our circles over the past couple of weeks. We're seeing the administration make some forward progress on things like transparency and site neutral and better reimbursing primary care and behavioral health that we've been pushing them on for years. But how does that gel or connect with congressional efforts? And are they complementary? Are they kind of getting in the way of each other? If the administration does this, does it kind of take away an incentive for Congress to act? And I mean, ultimately, like that is complicated, but I think we do see them as kind of pushing each other forward. I think the administration is taking some important steps here. We want to keep these rules as the pieces that we like as strong as possible. But it's still really important that that we push Congress to act and to put these things into statute, because ultimately that is what is going to ensure that we have some of these reforms for years to come, and that we can, importantly, to the last question, build upon them and go further. What we don't want is for whoever is in the administration to be kind of caught in an endless loop of litigation and kind of questioning on what what is the real meaning of this rule or Congress's intention. We ultimately need Congress to kind of get some of these pieces across the finish line and get them tightly in statute, so that we don't have to kind of keep revisiting through rules and responding to litigation and tweaks to rules. So all to say, I think we do see these efforts as complementary, and it's important we push the administration to do the right thing. It's equally important that we keep pushing Congress to do the right thing and to fulfill some of the promises that they've made that, frankly, as we've seen through major legislation passed this year, they have so far failed to make the system better and in fact worse. So just wanted to kind of add that context. And Mike, I'm seeing potentially more questions, so I'll turn it back to you.
Perfect. Perfect. 1 second. I think this is for you, Alicia. So are there any drawbacks related to the RFI on the inclusion of preventive care within the APCM bundle? She gives to give an example. For example, I heard a stakeholder say we don't need a separate code for depression screening to know it's happening, but we also can't track quality of care of that screening if it's without a code. Does that make sense?
Okay, yeah, I think I'm understanding the question, and definitely happy to set up some time and talk about this more one-on-one, or reach out directly, because want to be cautious of time here. What I will say is, we take a lot of our cues from the primary care groups, who are largely supportive, and if any are in the chat and want to drop a response to this in the chat, have been largely supportive of the APCM codes. I will say we can track quality of care and screening without a code, and that is through a different type of measures. And a lot of times, because of the burdens of coding is not always, I would say, 100% indicative of the services being delivered, especially for primary care and behavioral health specialists, in which codes don't always capture the scope of work they're doing. And so that would be kind of a first thought I would have, outside of the specificity of depression screening and billing that code individually. And Sophia, I see you're off mute, so I can throw this to you. But I'll also say there are quality metrics that track screenings, like SDOH screenings. We have quality metrics that do track that, the occurrence of screenings and when screenings occur and the results of screenings. And so in the absence of codes, we do have systems that allow for the tracking of the type of quality of care, and that is, something we can also advocate for alongside something like a bundled payment. And Sophia, go ahead.
No, and I was just going to add, I think it's a really important question, because I think, we're in this in-between place in terms of payment reform and changes to the way we're paying for care, right? We've got this longstanding fee, reimbursed based on a service or a procedure that's provided, a fee for service type of model. And then we have a full spectrum of payment models that are all the way to sort of the more reimbursement based on accountability for total cost of care and movement on health outcomes. And right now we've got this full spectrum, and we're in the sector, the healthcare sector, is in various places, but the vast majority of payments are still flowing through this fee-for-service model. And I think the big picture on this is the advanced primary care management, from our perspective, the APCM bundle is not the end game, right? If this is about a stepping stone, there's a glide path, I think, for primary care, in this case in particular, advanced primary care payment that we need. I think one of the biggest challenges in the transition to alternate payment models and payment reform is that because the physician fee schedule has built into the structure, the way we reimburse care, these distortions in how primary care is reimbursed, those distortions then get carried on into these other alternate, these sort of changing ways that we pay for care into the future. And we know that payment model is not particularly sustainable for certain types of providers. And so I think ultimately we want to get to a place where providers, primary care, are getting a lump sum payment in advance, where on an ongoing basis, so they can provide the care that they know that their patients need, and are held accountable for, are you moving the needle on improving health outcomes? Are you driving efficiencies in terms of quality, actual improvements in quality, in terms of patient-reported outcome measures and experiences? And there's a whole lot we could say on quality. But I think it's really important to note that because we're in this in-between place, I think you've got an effort to both strengthen the billing and the coding on the physician fee schedule side, APCMs, and you have efforts to move towards these models with greater risk and greater accountability for health outcomes and total cost of care. And so I think, hopefully that provides a little bit of clarity, or clear as mud, as I often say, because we are on this glide path, we're in this in between. And I think APCMs tries to get us some of the way, but it doesn't get us all the way. And there's a lot more work to do in that trajectory to create more sustainable payment across the healthcare system, and in this case, particularly for primary care and advanced primary care.
Awesome. Thanks, Sophia. We have one other question in the chat right now. Alicia, I think this is directed towards you, but really, I think all of you might have some insights on this. So the question is, the health equity measures are so important, but how should we make the case to the administration who is proposing to repeal them?
Big
Go ahead.
question.
Yeah.
And it was thrown to me first, but I will say, I think a lot of I have a lot to say here. I want to also make sure Sophia and Jane have time to answer, because I think that's a really critical strategy question. Something I will say on the SDOH piece are, we are in this Maha Health movement, and a lot of what we are seeing is a reframing of social drivers of health, of the healthcare that we've kind of named as the social health needs, health-related social needs. We see threads of this in the administration's actions through approaches to access, nutrition, language around nutrition, and other things. I think that there's a real moment here for us to be reframing and using maybe new language to really push for the effectiveness of SDOH, what we would maybe have previously called SDOH, or health-related social needs policies, the return on investment we get for those, and the way that those really intrinsically support health from where good health begins. And I'll pass it to Jane and Sophia.
It's a great question. And I think what I'll say to add to that is, I think what we just have to, it's for us to step back and think about who's getting these comment letters. And it's the career staff at CMS that are required to get these comment letters, to review them, to compile the feedback, and to bring forward the recommendations from broad stakeholders to their leadership, to the front office, to the folks, to the decision makers. And I think we have a job, and I think we as families would say, the way I see part of our role in the comment letters is to put forward really substantive comments that those career folks can take, and to help make the case to their leadership about important changes and feedback from the broad stakeholder community. That process is still happening. And I think on equity, I think we have a very challenging task where we both have to take a stand and make it clear that we oppose the changes that are being made, and also find a way to use the framework that this administration is using, and where there may be alignment, and maybe we change the language, but we're still making the case for evidence, for science, for making sure that these models are driving towards improving health outcomes and driving quality care, which you need evidence-based practices for. So I think, and at the core of that is like, I think bringing forward this argument, whether it's the non-medical factors, whether it's whatever the language is that we need to figure out. And I think there is some work to figure out what is the right language, right? But I think to Alicia's point, using that some of that MAHA language, to bring forth the fact that we can't get away from the fact that 80% of what drives people's health outcomes, if we want to make America healthy, drives health outcomes are these other factors. So if we need to change the language, if we need to change a measure, let's do that. But let's not step away from the ultimate goal, purported goal that we have, which is about having a more efficient, more sustainable system and making sure that folks can afford the care, have good care at a price that they can afford.
Great. Thanks, Sophia. Great questions. So I want to go just a few more seconds, just in case there's any last minute questions before we move on to the next section. So if there's any last minute questions, then put those in the chat now. Okay, so we're gonna wind down. And I want to wind down just giving you some potential actions that you can take that could have real impact over the next few weeks and months ahead. So the first is the most obvious, which is watch your emails. We have 2 comment letters that we just ran through that we hope to send to you in the coming days. And we hope that over this last 40 minutes or so that we've made a pretty good, compelling case for you to want to join those comment letters, sign on, and again, send a real clear message to the Trump administration on why healthcare affordability and quality is critical right now for people in the country. The second is Families USA is circulating a sign-on letter. You've probably seen emails over the last few weeks that we plan to send to congressional leadership as soon as they come back from August recess next week. Guys, this is a critical moment for our advocacy around Congress as well. We're about to see the repercussions of HR 1 go into effect, which means hospitals closing, premiums going up. Voters sent a message to Congress when during the elections that affordability really matters, and Congress has actually made it worse. So it's a really important time for us to send a very clear message that, look, you need to act now to address the affordability crisis. So we'd love to have you sign on to that. You have the deadline is by end of day Thursday, again, so that we can send it out next week as soon as Congress returns. Please feel free to do so. Third is Families USA runs a microsite called Same Service, Same Price. It's a great tool for educating the public or even like other advocates that you're working with from day to day. It has stories of people that are impacted by high and rising hospital prices. It has other resources, but currently, particularly in the moment right now, it has a great option for people to be able to send letters directly to their members of Congress urging action. So this is a great time. It's, again, starting next week. Congress comes back from August recess. It's a really important time for them to hear from their constituents directly that they need to act on these issues. So feel free to use that tool and get as many voices into them as possible. And lastly, always feel free to share your stories on high hospital prices and healthcare pricing abuses to stories@familiesusa.org. We are always happy to raise those stories to the national level and to make sure that they have as big of an impact as possible. So with that, I will give you guys all back 9 minutes And thank you for coming. And we will be in touch soon with the comment letters and all of the other actions that you could take. So have a great rest of your day.
Thank you all.